a spotkanie rozpocznie pani doktor Bożena Lackiewicz, prezes PMA, już tutaj. Dobrze, pani doktor, już można mówić.
Witam wszystkich zebranych na naszym nietypowym zebraniu naukowym, który dzięki właśnie technologicznym umiejętnościom naszego sekretarza możemy przynajmniej kontynuować naszą tradycję zebrań naukowych. Chwała Bogu, że udało nam się świętować nasze 75-lecie jeszcze na żywo, normalnie. No i jeszcze tuż przed pandemią mieliśmy jedno spotkanie naukowe, ale plus naszego tego zebrania jest, że więcej osób z daleka może się z nami łączyć. A tak jak Tomek powiedział, będzie to również nagrywane i będzie można sobie powtórzyć potem jeszcze raz. Naszym dzisiejszym prelegentem jest nasz członek, kolega, Mr. Tom Kurzawinski, Pancreatic and Endocrine Surgeon of UCLH, Royal Free, Great Ormond Street Hospitals. I cieszymy się bardzo, że zgodził się wygłosić nam ten referat. I also wish to welcome our non-Polish speaking colleagues and guests. The lecture will be in English, but the discussion can be in both languages. And we're very happy that we're able to meet, although it's rather atypical meeting. But at least it does give a chance of those from far and wide to join us, not only of distance, but even the weather. So I invite Mr. Tom Kurzawinski to give us his lecture. Prosimy bardzo, Tom.
Hello, can you hear me?
Yes.
Okay. Ja się nazywam Tomek Kurzawiński i jestem chirurgiem, tak jak pani doktor powiedziała. Nie pracuję już w Royal Free, ale pracuję w dalszym ciągu w UCLH i w Great Ormond Street. Ponieważ wykład jest zawsze po angielsku, to ja się teraz przełączę na angielski, ale tak jak pani doktor powiedziała, oczywiście mówię płynnie po polsku i dyskusję będziemy mogli prowadzić po polsku i po angielsku. Now, I'm going to, Tomek, share the screen now. And you give me okay that is actually visible.
Yes, it's okay. Yes, so fine, you can start.
Yeah?
Yep.
Okay, so lovely. Once again, thank you very much for inviting me. I thought that we're going to talk about surgery, and I promise not to mention coronavirus even once. So we will take you to slightly different field of the medical practice. And when I was asked to give this lecture, we didn't have much time to prepare it. So I gave you the quite wide title, which allowed me over a period of last week insert into that presentation the things which I thought might be of some interest to you. And obviously the famous Vadis for most people out there comes from the Bible, but for us it comes from Henryk Sienkiewicz. And that's exactly how I this quote, how I can see it. So the first thing when we talk about the surgery, maybe it's worth, so I'm just going to collapse it, to find a definition or talk about the definition of surgery. And the surgery is a branch of the medical practice which treats injuries, diseases, and deformities by physical removal or repair or readjustments of organs and tissues. And I think what is particularly important in that definition is that it's often involved, what is often involved is cutting into the body. So if you try to do any of these things without actually producing an incision, it's not called surgery, it's endoscopy or interventional radiology and so on. Now, so if you don't like long definitions, you can always say that surgery is a violent remedy. And because of this perception that surgery is a violent activity, surgery as such has got a little bit of a reputational problem. And many people see surgery as marginal, expensive, and something which can be phased out of the medical practice ideally. But we are quite far away from that. I presented, I prepared this talk in such a way that it's very general and hopefully of some interest to all of us. But according to the World Health Organization, about 30% of the global disease burden is actually surgical, which means that 30% of the diseases can be cured by surgery. There are about 313 million surgical procedures performed worldwide each year. So it's a very, very big area. And this 300 million operations are performed by just over 1 million surgeons, 500,000 of anesthetists, and just about 500,000 of obstetricians. So the number of the people who actually practice with their hands is quite big. And the number in brackets are the number of surgeons, anesthetists, and obstetricians in the low and middle income countries, which straight away tells you that most of us sits in the developed countries. And that is a little bit of a problem for the rest of the world, because 20% of surgical workforce in high income countries are international graduates, a little bit like me, meaning that the surgeons from low and middle income countries, they migrate to the high income countries and make the number of the surgeons in poorer areas even less. And just to assure you that I didn't make up this data, that they are quite reliable. All of these numbers come from the Global Surgical Workforce Database, which surveys 167 countries, which probably covers about 92% of global population. Quo Vadis surgery. So my talk is going to be fairly general. I just a few slides of general introduction to surgery, and then few examples from my own practice. So it probably will be a sensible thing to realize how far surgery traveled. I always like to think that you know, the basic development of surgery was development of a sharp knife, and that must have happened some thousands and thousands years ago. But surgery benefited from many, many other innovations. The cardiovascular bypass allowed us to operate on the heart. Obviously, the implants completely changed the orthopedics, and there are so many millions of people walking around with joints, hips, and knees. And obviously, the development in optics allowed us to minimize the invasiveness of the surgery, and the most recent development is robotics. So this road which we walk is peppered constantly with the new developments, and these developments which here on the slide is sort of technical developments or physical developments, but surgery also immensely benefited from other innovations which came from the field which were outside surgery, the antiseptic, the anesthesia, the antibiotics. You know, without these inventions, safe surgery would not exist. And there are some others, such as like an organ preservation and immunosuppression, which allows us to do transplantation. So surgery is definitely an interdisciplinary field. Now, somehow, because of that violent remedy label, it is generally perceived that, that you know, if you take these two characters of good, bad, and ugly, then you know the medical treatment with medications always think as a sort of preferred alternative, and a surgery is seen as a sort of a bad, painful procedures which carry the risks of complications or even death. However, the third fellow standing on the slides, the ugly, you know, this applies not only just to surgery, but to medicine as well. So it is true that according to the WHO, there are 4 million people who die 30 days after surgery each year. Now that's a very, very big number. And that is 7.7% of the global, of all the deaths globally. Now, I didn't know that before I put up this data for this presentation, is that people dying after the surgery, that is the third greatest contributor to death after ischemic heart disease and stroke. And number of these deaths are more than combined from malaria, HIV, and tuberculosis. Now, obviously, it doesn't mean that all of these 4 million people, they die because of the complications or badly performed surgery. Some people have surgery and they just can't be saved and they die as a result of it. But it's still a very impressive number. But please remember that there is a very, very significant number of mortality and morbidity caused by the medical treatments too. Surgery is not alone. So according to this data from the USA Institute of Medicine, about just over 250,000 people died in the hospitals from iatrogenic causes, which are not surgical. 7,000 died because of medical errors, 20,000 because other errors, 80,000 because of the infections, and about over 100,000 die because of the medications which were given. And it's not necessarily as an error, but the medication was given with good intention, but patients develop complications. Probably the best example would be chemotherapy. So this comparison or competition between the surgery and medicine goes on, and I put it in sort of football terms because surgery sometimes is better than prolonged treatment with the medications. Now, the favorite example of that is the treatment of the peptic ulcerations. Those of us who graduated 30, 40 years ago would remember various forms of surgery, which were essentially now completely disappeared. And this is a very good example how the medical treatment completely outperforms surgical treatment. So that is sort of a win on the pills side. However, if you look at the problem of the obesity, it's other way around. It's also an operation on the stomach. But if you have a seriously overweight patient, there are no really tablets which would help him, but the surgery still can do. In my own field, let's say the overactive thyroid, there is a little bit of a draw as both of these medications and surgery can be quite safely applied, and the probably number of the patients being treated each way is probably 50-50. And there are other examples. For example, if the liver fails or the kidney fails, and for all the talk about stem cells, we still can't grow organs. We have to get organs from the donors and transplant them. And obviously, even in the solid cancers, I especially say even because the oncology made such enormous progress in the last 10, 15 years. Surgery is still seen as the most efficient way of getting rid of the tumors. And if the cure can be achieved by surgery, then the oncological treatment might be not necessary. So those initial slides are just to give us an idea that the surgery is still a very, very big player in the medical fields. Now, I don't know how many trainees we have today, but obviously, if you are a trainee and if you want to create your waves in various specialties, then you've got a lot of things which one can consider. And in surgery, sorry, I'm just going to give myself a laser pointer. Here we are. So surgery, progress in surgery and the inventiveness in the field is very also associated in my opinion, quite narrow with the robotics, with the minimal invasiveness and so on. So today I just would like to give you a few examples from my own field, that the surgery is benefiting from new developments, which sometimes comes from unexpected fields. So I would like to give 3 examples from my own practice, how the surgery has developed. The first one will be in genetics, then a little bit about point of care testing, and a little bit about molecular biology and the impact of the discoveries in this field on surgery. So the first one is genetics. You know, genetic really started in 1866 with Greg Mendel, and it was 100 years later when Watson and Crick discovered the structure of a DNA. And only 50 years later, we've got the Human Genome Project. So if you, in my view, advances in genetics are probably bigger than in any other fields of biology in the last 20 to 30 years. And we are now bombarded with a number of genes which are being discovered. And many of genes had huge impact on surgical practice. And today, as an example, I just want to tell you about the red gene, which is the rearranged during the transfection gene, which was identified in the 80s and cloned in 90s. So red is a highly conserved gene and is present almost in all organisms. So it is in little flies, and it's in higher primates, and definitely in humans. The expression levels are highest during the development and then decreases substantially as we grow older. And it is very important for the formation of the neural crest, urogenital system, spermatogeneal cells, and the cells from the central and peripheral nervous system. So on this slide down here, if you have well-functioning red, and you develop kidneys and a bladder and various other structures, but if you don't have that particular gene functioning normally, then you've got that agenesis of the urogenital system. It's very important in the embryonal development, and interestingly, like any gene, it can mutate, and if it mutates, there are many different diseases which can come from the mutation of that one particular gene. If the mutation introduces loss of function, meaning that the gene is just not functioning very well or underperforming, you get a Hirschsprung disease, which is the megacolon, which is children are born and they can't open their bowels and they go into obstruction and they need part of the bowels with the agangliosis removed. They can, this loss of function mutation can also lead to underdevelopment of the kidneys and bladders. However, if it is a mutation which introduces gain of function, meaning that the signaling down that particular pathway is increased, you get a different type of diseases. You get a multiple endocrine neoplasia, familial medullary cancer, and sometimes other forms of cancers, and that includes non-small cell lung cancer. So we call it a chameleon gene, because it can, one gene can be responsible for so many different diseases. So from my particular field, I just want to tell you a little bit about multiple endocrine neoplasia type 2. It's an autosomal dominant inherited disease, meaning that if the parent has that particular mutation, then a child has got a 50% chance of inheriting it. There are different types of multiple endocrine neoplasia. For example, multiple endocrine neoplasia type 2A, these patients develop medullary thyroid cancer, primary hyperparathyroidism, the pheochromocytoma. In 2B, they develop only medullary cancer and FEO, and if the FMTC, they develop just a medullary thyroid cancer of the thyroid. So even within the mutations, there's a wide spectrum of presentations. It's a fairly rare disease. It occurs in about 1 in 200,000 live births, and the estimated prevalence is 1 in 40,000 individuals. So in the United Kingdom, there are just few hundred of people with that particular condition. So it definitely qualifies as a rare disease. Interestingly, majority of these problems are inherited from parents, but there is one particular type of a disease called 2B, when almost exclusively the children are the first one to develop the mutation. So the parents are healthy, and it is the children who are born with these conditions, which obviously is a great challenge to diagnose it early, and I will tell you in a moment why. So within this big spectrum of multiple endocrine neoplasia, and in the wide spectrum of various organs involved in this disease, it is almost always that they develop medullary thyroid cancer. 99% will develop it. Now, how quickly they develop this cancer depends on the type of the mutation. So the first, this slide shows the mutations, which is RET634, which is the commonest mutation causing that problem. So the child is born with a normal calcitonin C cells or calcitonin producing C cells. Within the few years, the cells undergo the hyperplasia, and within few more years, they develop medullary thyroid cancer, which then metastasize to the lymph nodes. So because we now have ability to genotype and test for this mutation, there is obviously that opens a possibility of an early intervention and preventing developing a medullary thyroid cancer. And a similar chronological development is when it comes to developing lymph node and distal metastasis. So it's just a matter of time. Now, all of these mutations are put into 3 or 4 groups, and they have different risks. So the 2B, the one which we were briefly discussing on the previous slide, this is a mutations 918. Now, this is such a dreadful mutation that the children develop medullary thyroid cancer within the first year of life, sometimes within 3 to 4 months. So therefore, the recommendation is that if you can identify these children, and they're quite difficult to find, and they should have an operation as soon as possible. Now, most of the patients belong in that, so this is the highest risk group. And the other groups are, the risks are a little bit smaller. This is the commonest with the mutation 634. So the official recommendation is that they should have an operation and a thyroid removed before they are 5 years old. So about 10 years ago, because these operations have been performed for the last 20 years, but we didn't really have that much of an idea of what's going on, I formed a RET research collaborative network in the United Kingdom and Northern Ireland, and we started putting the results of surgery on these children. We published the results last year in the British Journal of Surgery, and we also organized a very successful meeting about the RET mutations at RET at CRIC, which took place last year, almost exactly a year ago. So I want to show you, this is all very specialist knowledge, but this is just an interesting example of how genetics can be applied in surgery. So when we look at all the children who had an operation in the last 20 years in the United Kingdom, you can see that most of them have the genetic test sort of before they are 5 years old, but only 52% of them actually have the test as soon as recommended by the guidelines. So we're not doing terribly well there. And does it matter when we test these children for the mutations a little bit later? Well, it does, because the children who are tested for this mutation later, 76% of them have elevated calcitonin levels and 55% of them have already a cancer. So it is very, very important to test them quickly. And similarly, please ignore the ABCD, because this is the analysis for the subgroups, which I don't think you would be interested. We're just focusing on the first column. So the median age of surgery is when the children about 6. So we are operating a little bit too late. And only half of the children have an operation by the time recommended by guidelines. And again, if you operate late, they have abnormal calcitonin and they have medullary thyroid cancer already there. So it's just important how the tool is there, but it has to be used, and it has to be used timely if the treatment is going to be effective. This slide is about, essentially these children need broadly 2 types of surgery. Are they removing of the thyroid alone if they don't have metastasis, or the lymph node dissection? And in our series, only 13% of children had normal thyroids. Now, that doesn't mean that the operation was unnecessary. That is an ideal timing. You remove the thyroid before all these problems start. About half of the children had hyperplasia, which is still a benign condition, so that's good. But 38 of the children had medullary thyroid cancer. Generally speaking, these operations in the United Kingdom are done quite well. On average, children stay in a hospital for about 3 days. The complications related to the recurrent laryngeal nerves or bleeding infections are very, very low. There is only one but very big problem, which is that thyroid surgery in such a small children interferes with the little parathyroid glands. Therefore, they develop quite a lot of hypocalcemia. And about half of the children, the calcium drops on the day after surgery, and then it gradually recovers. But we still have a substantial number of children which need calcium supplementation after surgery at 12 months. Also, our most recent publications also suggest that they carry on recovering even beyond 12 months. So generally speaking, these operations are done quite well, but the hypocalcemia remains the problem. Now, we judge our success by measuring the calcitonin levels, because that is the biomarker which is made by the C cells. So in that particular cohort of patients, 38% have an undetectable calcitonin. That is the best, because that means that they are cured. 28 have a calcitonin within normal range, so we're actually not quite certain what's going to happen next. But sadly, about 1/3 of the patients' calcitonin is a little bit higher than normal. So, we don't expect any major problem this year, next year, or even in the 5 years, but in the 10, 20, or 30 years' time, they might develop the cancer. Reassuringly, only one of the children in that particular series develop clinical recurrence. So all of this other worry here is a biochemical rather than clinical. I'm going to skip the slides. So, these children are very small, and obviously one of the problems, and I don't know whether you can see that slide, the numbers, but we perform about 5 or 6 operations a year, and only Great Ormond Street performs a substantial number of them, and there is a little bit of situation there are some hospitals where the surgeon performs only one of these operations in his lifetime. So there is obviously a need for some sort of centralization. So the children can go to the 2 or 3 centers in a country who actually has got an experience in performing the surgery, and that obviously will improve the outcomes and hopefully will help with getting rid or reducing the risks of the hypocalcemia. So this is the first example, which is a genetic. Now, the second example of how the surgery works with the other fields, and especially technology, is the operation for primary hyperparathyroidism. So it's another thing I do. Now, I don't know how much you know about the primary hyperparathyroidism, but in a nutshell, one of the parathyroid glands gets a little bit bigger, starts making too much parathormone, and people develop a hypercalcemia. Now, it is quite a big problem, because if you look at the prevalence of this condition in the United Kingdom alone, it's about 60 to almost 500,000 people. And about 12,000 people develop this condition every year. But this condition is quite underdiagnosed and not very well treated. And we perform about 4,000 parathyroidectomies a year, which, if you actually look at the prevalence, is just like a little drop of water in the ocean. And similar figures can be extrapolated for various other populations. Now, many people view that as a benign disease, because when the disease is discovered, many people are asymptomatic. And obviously, you know, it's a benign in oncological sense, but it can affect the quality of life quite significantly. And again, the medical students for many years been told that it's moans, groans, and bones, and so on. So they can develop tiredness, depression, pancreatitis, kidney stones, and very weak bones. But the discovery of the last few years also suggested that people who have successful surgery for this condition have a better survival. So it's not just moans, bones. And that is because this condition is associated with a higher rate of cardiovascular problems, heart attacks and strokes. So there's a change in the general perception of how this condition should be treated, and much more patients nowadays are offered surgery. Now, the standard way of operating on parathyroids until about 20 years ago was to, you know, the operation was very similar to that of a thyroidectomy, when a 5-6 centimeter incision was performed and the glands were identified and the big ones were removed. And, you know, the results were excellent, but the scars were quite big. So what happened in the last 10 to 15 years, the surgeons developed what's called minimally invasive parathyroidectomy, which is done to a very, very small incisions. And obviously that it is not just the cosmetical effect, but it's a smaller operation, less pain. So there are other benefits of doing it that way. There are several technologies which the surgeons try to apply to make this operation very successful. One of them was to test the parathyroids very quickly using a frozen section. Some people use the radioactivity to detect them. Some people use the radioactivity to measure the radioactivity in the specimen they removed. And obviously, there is a technique when you inject the methylene blue, but it's got significant disadvantages that people do go a little bit blue for a little while, and some have a quite severe allergic reaction. So we consider these technologies a rather old-fashioned and obsolete. Now, the reason why the rhinoceros is there, because parathyroid glands were first discovered in a rhinoceros when Richard Owen dissected a rhinoceros in a London zoo. So everybody in the field of parathyroid surgery in medicine know what's the association with the a rhinoceros is. Now, if this operation is going to be performed in a minimally invasive way, you have to have some sort of idea which of the parathyroid glands is faulty. And that is usually achieved by performing an ultrasound, which is accurate in about 70 to 80% of cases. And you can perform a CT scan, and you can add a little nuclear scan called sestamibi scan to it, and you can find out which of the glands are successful, are enlarged. Now, the problem that as good as these tests are, they're not perfect. So they only give you some sort of idea where these glands are. But you need a technology which will tell you during the operation that you have removed the right gland and the patient is cured. And interestingly, this technology has been developed, and this is called the intraoperative PTH measurement. And it's based on the fact that the parat hormone has got a half-life of only 5 minutes. So when you start an operation, let's look at the pink curve here, then the parat hormone is abnormal at 40. As you approach the gland and you start manipulating, then obviously the hormone levels go up. But from the moment of a resection, it will half every 5 minutes. So you can wait for 10 minutes, do 2 or 3 measurements, and if you achieve that particular trace, then the patient is cured. Sorry, that was my phone. So we introduced this technology about 20 years ago, but we didn't have ability to measure the hormone in theater. So at the time we were still working in the old Middlesex hospital, and we operated somewhere here, but the sample had to go to the lab and come back. So it took us a very long time, probably an hour delay. And obviously patients were anesthetized on the table. So we were very relieved when one of the companies in Holland developed a new system when you could measure the parat hormone levels in theater very quickly, within 10 minutes. And this is the machine which we're using currently. We published our results a couple of years ago. And if you use this technology, the success rate of curing the problem is quite outstanding. The cure rate is 97.6%. So that is that sort of statistic, which is quite unique for surgery. And we were also able to perform 80% of these operations using minimally invasive technique. So it's a wonderful development which came to surgery from the field of point of care testing. There's only one problem, that logistically it's quite fast, but you need a scientist in the theater all day to keep measuring the hormones, and obviously very difficult to organize. So we spent the last 5 years building a new device, which is actually quite difficult. But we had some limited success that we will be able to measure it in a drop of blood, only 3 minutes. But the whole process will be so simplified that the surgeon or anesthetist can do it himself. So it will be much easier to organize these operations, and the benefits of using this technology are quite obvious. So this is the second example from my field. And the third one is something to do with the adrenals, because as an endocrine surgeon, I do thyroids, parathyroids, adrenals, pancreases. So I have chosen 3 different fields to illustrate how the surgery benefits from the progress in other fields. Now, the primary aldosteronism is a condition when an adrenal gland starts producing too much aldosterone. As a result of that, the blood pressure goes up, and patients present with a very high blood pressure, which is difficult to control, and a low potassium. And this condition has been described 65 years ago, and last 50 years it was considered a rare problem which should be treated with tablets, and only very occasionally patients were offered an operation which could be curative. Now, what has changed in the last 5 years is that it is now generally accepted that the condition is common, is not rare. Everybody knows or believes or accepts sorry, my phone's playing again, that, that the incidence of people with hypertension is about 10% in any Western population. And about 10% of that 10% has primary aldosteronism. So the mathematics tells us that about 1% of the population has got that problem, which is a lot. So suddenly the realization how common this problem could be has changed the perception of it. The other big problem or realization came from the fact that it is not good enough to control the blood pressure. That if you compare patients with that particular condition with patients with hypertension and you match them for age and for sex and the severity of the hypertension, the prognosis and the outcomes are still much worse in patients with primary aldosteronism. And this is because this additional morbidity is caused by the high levels of aldosterone. So all the complications, you know, the high blood pressure contributes massively to it, but the presence of the aldosterone itself is also very important. Now, sadly, everybody accepts that it's a common condition with high morbidity, but the route to surgery is very, very long and twisted. If you accept a figure of 1% in our population, then only 300 adrenalectomies for that condition are performed in the United Kingdom, which is not many. And let me just try to tell you why this, I think, is the case. So on this slide, this is the cortical cell, which makes many things, including aldosterone, but we are interested in the production of aldosterone. So essentially, this is a kidney. You will be familiar with the concept of juxtaglomerular apparatus, which starts secreting renin when the blood pressure drops. The renin acts on the receptor. Aldosterone synthase start producing aldosterone, and aldosterone goes in the blood to kidney and absorbs the sodium and maintain or elevates the blood pressure. So that's how it works in physiology. Now, in the last 10 years, we have discovered several mutations on the cell, and this mutation can lead to depolarization, and then the calcium ions flow into the cell and the aldosterone goes up. But it goes up in an uncontrollable way. So it's a loop which is not performing very well. And what happens then, that if you want to discover that that is the problem, you have to measure the aldosterone in the blood. But it is quite difficult to diagnose this condition. Essentially, if you want to diagnose this condition, you have to go through 3 steps. First, you measure aldosterone and renin, but that alone is not enough to make the diagnosis. Then you have to go through the confirmatory test when you give patients saline either orally or intravenously, and then you measure the aldosterone response to it. And that's not the end of the diagnostic process. You have to do a subtype classification. You have to find out which of the 2 adrenal is responsible. And to do that, you need to do a CT scan. And it is now recommended that you have to insert a small cannula into the groin and go all the way directly from the groin to the adrenal veins and measure the aldosterone concentration. It's a very difficult thing to do, and the failure rate of this procedure is very high, although some radiologists are very good at it. So at the UCL, the Department of Radiochemistry invented a new way of loading fluor into the small molecule drugs. So this is the basing compound which has been developed by Merck, and this is the inhibitor of the aldosterone synthase. Now, it was developed as a medication, as a drug, but it has been dropped because of the various side effects. But the chemist or radiochemist thought that it's a wonderful opportunity that because this molecule in itself already has few fluor residues, that it would be very clever to introduce the isotope, which you can see on a PET scan, and use it as a diagnostic test. Now, we are not the first to have that idea, and there are various other groups which are working on it, and actually the metomidate scan is already available, but they all have serious shortcomings, which I probably will not go into because we try to keep the stock in general terms. But it seems that the metomidate, which is done in Cambridge, has got significant disadvantages. This one is in the King's, also has disadvantages. This is a consortium between Japan and Mayo Clinic in America, and this is a Germanic consortium. But it seems that the compound from the UCL is better than others. We have performed a series of experiments on the adrenals, and those are the human adrenals from patients with the primary aldosteronism. So if you stain them with monoclonal antibodies for the enzyme which makes steroids, this is not discovered by the radioactivity. But if you stain it for aldosterone synthase, you can see that there is a beautiful correlation between staining with the monoclonal antibodies and the autoradiography. So it's got a great promise. And we now been funded to perform two types of trials or research projects. One is the development of the adrenal tracer, when we will continue the work of autoradiography in various adrenal glands. And the other one is called IDEAL, which is the image-derived enzymatic adrenal lateralization, which will be giving this compound to the 12 patients with Conn's disease. And that is the first in humans study. So essentially, if you remember that diagram as to how the system works, we, instead of keep measuring aldosterone, which is very difficult, and essentially we think that quantifying plasma aldosterone is the reason why this condition is so underdiagnosed, we will replace it with quantifying the tissue aldosterone synthase. And that is only possible because Merck developed a very, very highly sensitive inhibitor of that enzyme, and the radiochemist at the UCL inserted a radioactive isotope into it, which will allow us to do that. So what is the advantage of this new development? It will have an enormous impact on surgery. Instead of very long and twisted and difficult pathway, you will be able to do a scan. You will be able to diagnose the condition. You will know straight away which adrenal it is. Then you will be able to do an operation. And then that is the offending little adenoma. And the operation, if it is performed in the right circumstances on the right patient, is very likely to be curative. And this is just a slide to remind us that aldosterone was actually discovered by this wonderful lady called Sylvia Tate. It was at the Middlesex Hospital in London in 1953. So that is really the end of my talk. I hope I didn't go on for too long. Essentially, I gave you a little bit of an idea as to what surgery is and how big surgery is global-wise. And I gave you 3 examples which demonstrate how surgery benefits from the developments in other fields, not just what is currently quite common obsession with the develop new minimally invasive tools. There are many other ways the surgery can benefit from. So I like this very old saying, a fable about the hedgehog and the fox. It has been used by Isaac Berlin when he wrote his book about Tolstoy. But actually, Isaac Berlin did not invent that anecdote. It came from the Archilochus, a relatively unknown Greek philosopher. But essentially, the hedgehog knows one big thing, but the fox knows many things. And I really think that the surgery is an interdisciplinary game, and we will all benefit if our surgeons engage with other disciplines. And one last thing, thank you very much for listening.
Super, świetnie, dziękuję bardzo. Bardzo ciekawe. I myślę, że będzie na pewno trochę pytań. I bardzo proszę, jeżeli ktoś by miał ochotę zadać pytanie, to zapraszam. Można po prostu się odmutować, czy unmute i zadać pytanie, ale można też, żeby było troszeczkę więcej porządku, zrobić jest na dole przycisk reactions i można zrobić rączkę i wtedy też ja mogę to zrobić, czyli odmutować, a też można napisać pytanie na czacie. Jest na dole, powinniście mieć Państwo na dole ekranu taki przycisk czat i można po prostu napisać pytanie, które też Tom zobaczy. Ja chciałbym, jeżeli można, to rozpocząć pierwszym pytaniem. Ty mówiłeś o tych dzieciach, które mogą mieć nawet rak w wieku kilku miesięcy, co jest dość wstrząsające, a powinny być operowane w wieku kilku lat. To czy ja jestem GP, czy jest jakaś dla mnie szansa, czy dla tych dzieci szansa, żebym ja mógł też rozpoznać mutację tego genu RET, czy jakieś symptomy albo objawy, coś, co dałoby mi do myślenia, żebym sobie przypomniał twój dzisiejszy wykład, pomyślał, o, to może być to i może rzeczywiście warto go szybko to dziecko zreferować. Co myślisz?
To dobre pytanie, Tomek. To jest dość trudne. To znaczy, te dzieci w zasadzie można by sklasyfikować w 2 grupach. Większość dzieci rodzi się w rodzinach, gdzie jedno z rodziców already wie, że ma mutację. To 80-90% tych dzieci rodzi się w tego typu rodzinach. I wtedy jest opportunity, there is an opportunity to do the genetic testing very quickly. And that's what we recommend nowadays. And then, it's very, very important because, there's a 50% chance that the child does not have a mutation. Well, if the child doesn't have a mutation, that child doesn't need any treatment or follow-up or anything. But obviously, if the mutation is there, then you have to trace the calcitonin levels twice a year. And, by the age of 3 or 4 or 5, you should do that, the operation. So these children are asymptomatic. They are diagnosed only because their parents had the mutation, so they are just tested. The second scenario is that suddenly a parent is diagnosed with this condition. Well, let's say at the age of 30 something, it's possible. And then if the mutation is positive in one of the parents, then obviously it's very often they already have children. So we retrogradely test the children, but the children could be older than 5. So there's a possibility of missing the opportunity to cure. But your question really relates to the children with 2B, because those are the children who have 2 healthy parents, and they are the first ones to develop this mutation. And they are extremely difficult, especially you have to click very quickly. And the only indicator here is, first of all, they could have Hirschsprung disease, which is severe constipation. And the other one, they develop little fibromas on their tongue and lips, but they develop these things later. They don't develop within the first few months. So for you as a GP to pick it up, it would be extremely, extremely difficult. But if you have a child with a very severe constipation and some facial features with the ganglioneuromas on the tongue, then that diagnosis should be considered.
Super, dziękuję bardzo. A czy mogę Cię, tu już widzę następne pytanie jest na czacie, czy mogę Cię poprosić, żebyś zatrzymał sharing? To wtedy chyba będziemy też widzieć te osoby, które zadają pytania. Będą się, jak się zaczną mówić, to wtedy się zobaczymy też wszyscy na ekranie.
I can't, just let me.
Super, widzimy Cię całego. I tak jest pytanie tutaj na czacie od pani dr Marii Butler. Are there any use of robotic operation in your field?
Not really. I have to admit, I am not a great enthusiast of robotic surgery. First of all, I just don't think that it's really robotic surgery. You know, the robots which are called robots in the medical practice, they are essentially instruments which are used by humans, and you move the arm. So it's nothing to do with the robotics. You can take a pair of scissors and you can call it robotic because, you know, I move it and they do the job. So no. The thyroid surgery performed robotically is performed mainly in Asia and a little bit in the United States, but I don't perform it because it's a very big and quite dangerous operation, and the only advantage is avoiding the scar in the neck, and the scars are most of the time very good anyway. We have looked at the adrenalectomies, but adrenalectomies we performed laparoscopically, so we do it through the very small holes, and there is no advantage of adding a robot to it. In fact, it will just make it very expensive. There are some pancreatic operations which are performed robotically, but again, they can be performed laparoscopically as well. So in my field, no. I mean, the only field where the robot sort of more or less proven itself is prostate surgery, but I don't do that.
Super, dziękuję bardzo. Czy ktoś jeszcze ma pytania? Tu przeglądam, nie ma żadnej podniesionej rączki, nie ma nic na czacie. Może po prostu, jeżeli ktoś ma ochotę zadać pytanie, proszę się unmute i
Chciałem zapytać tutaj Piotr Rosarek, bardzo ciekawy wykład. I just want to ask you in English, Tomek, what your thoughts are on minimal residual disease, or surgical debulking in terms of oncological operations. Ovarian cancer would be probably the disease that's been where this has been practiced for a long time, doing debulking surgery and then chemotherapy. But particularly in my field at the moment, mesothelioma, there's a trend for doing previously, big operations. Extrapleural pneumonectomy was something that was in fashion some years ago. The Americans particularly were promoting this surgery, and a big UK study called Mars showed that this was actually trended for worse survival than not doing surgery. And now there's a big trial, Mars 2, which is looking at a more more conservative operation of pleural decortication. So yeah, just from your perspective as a surgeon, your views on these type of oncological operations, because as far as I know, even in ovarian cancer, there are no key studies. Maybe Agnieszka Michael, who's on, I think, can speak to this as well, of good randomized studies showing an improvement in survival with surgery. But your thoughts would be very much appreciated.
So-called debulking surgery. I mean, this term existed even when I was a trainee in 80s, and obviously, the whole concept of oncological surgery came from Halsted, who made all these huge operations on the breast, which included removing of the pectoralis muscles, and we now know that it is absolutely not necessary. I think that to answer your question, one would have to take one cancer at a time, because I don't think that the answer exists which will cover proper response to just one answer to all of the cancers. So I have very little experience of mesothelioma, although my wife is a chest physician, so I have some experience, sort of discussions about that. But in my field, so if you just take one by one, cancer of the parathyroid is so rare that we probably shouldn't even talk about it. Now, a thyroid cancer. In a thyroid cancer, if the patient is diagnosed with metastasis to the bone and lungs, you will still do an operation in the neck to remove both cancer and the normal tissue. But that is done to facilitate the treatment with the radioactive iodine. So, you know, we know that we're not curing, and you can use a definition of debulking here, but it is not that the debulking will affect the prognosis. It is just that the debulking will facilitate the treatment, which is actually quite effective. So that is, let's say, in thyroid cancer or differentiated thyroid cancer. Now, the cancer I was talking about today, the medullary thyroid cancer, there are still many surgeons who recommend a massive operations, including opening chest, clearing the lymph nodes. The problem with a medullary cancer is that you have to do it very early, because tumors as small as 2 to 3 millimeters can metastasize. And there is very little benefit from performing this huge operation just to debulk disease. But there is a very good news on the horizon for the oncologists who are listening to our debate. Will be familiar with selpercatinib, which is the new RET tyrosine kinase inhibitor. We all know the multi-kinase inhibitors, but this is the one from Loxo. And during this meeting I organized last year, we involved the pharma, and we now giving this drug to 5 children, age from 2 to 8, who were diagnosed with a medullary thyroid cancer with this 2B multiple endocrine neoplasia. And on some of these children, I operated twice, and the calcitonin was still 30,000. And we just have the first 6 months on the first child, and her calcitonin came down from 30,000 to 100. So, it is, the surgery has to exist within a milieu of other specialties. The surgeon really has to have a very good understanding of what is available in oncology and what the oncology can do. And the radioactive iodine for differentiated cancer and this new monoclonal, not a monoclonal, a small molecule, is very good example. The third example from my field is adrenal cancer, a dreadful disease. And some people say that debulking can improve prognosis. I don't think so. I don't think there's any evidence for that. And because there is no really good drug which can be more effective after debulking, I think that these massive operations probably should not be performed.
Thank you very much. Very helpful.
I can just add to Piotr's comment. I think in ovarian cancer, it's a little bit like you say, Tom, in other specialties where there is no doubt about the role of the surgery. However, the treatment afterwards is the one that will define the extent of the surgery. So with improving drugs in ovarian cancer, the role of the ultra radical surgery, when you aim for sort of no residual disease, is probably not going to be as important in the future, but it's still open to debates, and surgeons probably would say a different thing that I've just said.
No. I really think we have to move from. First of all, I really think that surgeons are slightly different animals nowadays compared to what they were 20, 30 years ago. Although we still see exactly like this, we're sort of butchers and, you know, men with blood on his shoes, and we do have blood on our shoes. But I think that modern surgeon is so much involved within his or her specialties. Look at the breast surgeons. They are like little oncologists. They actually understand the oncology quite well. And the gynecologists also perfectly understand all the most recent trials of ovarian cancers, because I operate with them, you know, on the same day. So I know that. And the colorectal surgeons, you know, the colorectal surgeons are not just people who take the colons out, but they have a very good understanding of what can be achieved by the post-operative treatment.
Okay,
May I
yes,
ask a question? Now, there are certain guidelines who can be referred to genetic testing. For example, as far as I understand, with breast cancer, you have to have 3 relatives young age or 2 relatives young age before genetic testing. Let's take a scenario that you have a patient who whose father was diagnosed with pheochromocytoma. Now, is it enough to have one parent diagnosed to refer the whole family for genetic testing?
So again, excellent question. I have sort of like 2 or 3 layers of response to that. First of all, the explosion in genetics is so rapid that the force, you know, the workforce of the geneticists is just nowhere near to keep up with the demand. So we are very active. Well, I am of a view that the clinicians like myself, we should be allowed to send patients for genetic testing without a consultation with a geneticist. It would be a better way, but if they have to wait a year for a consultation, you know, it's not applicable. So this is the first thing, that, you know, the time will come that the specialist in a certain specialty should be able to order genetic screen for genetic mutations, whether it's a panel or is it a genome or any form of the mutation of the analysis. The second answer is that in pheochromocytoma specifically, if they have a pheochromocytoma, 25% of them have mutations. I don't mean somatic mutations, I mean germline mutations. So they inherited a gene which predisposed them to the pheochromocytoma. And because the percentage is 25%, is high enough just to send them for the genetic testing without any family history. So it's 25% in pheochromocytoma. It is 25% in medullary thyroid cancer. So any patients with this condition should have a panel. In medullary thyroid cancers, it's always red. And in the pheochromocytoma, it's 8 different diseases, including multiple endocrine neoplasia, but also other germline other diseases which are caused by germline mutations. Now, the third answer to your question is that how many of the people in your family should have that particular cancer before you start thinking that it might be familial. Well, I had a very good chat with the geneticists from St. Thomas's about it, and they told me that 1 is never enough. Mm. If you have 2, then the rate of a pickup is 20%. But if you have 3, it's more than 50. So I don't think that you should think of a familial disease when there's a history of the auntie having breast cancer. But 2 is, well, you can start thinking about it, but the pickup rate will be relatively low. But if it is 3, then the chances that there is a germline mutation to be discovered is 50%.
Thank you.
If I could give a general question, that we know that surgeons don't do much research but you obviously do. I wondered whether you'd like to make some comments about how you could encourage surgeons to become more research active, given the great difficulties that we know we go through. And I know especially at UCLH, we have incredible difficulties getting our research organized. But have you got some tips for how surgeons could be doing more research?
I was very lucky to work with surgeons who always valued the research. And when I was younger, you know, we all worked in a very big department. They were called academic departments of surgery and then university departments of surgery. Now the problem came when the assessment programs came. And suddenly the surgeon who was doing 10–20% of his time research was competing with, you know, astronomers and molecular biologists who could attract grants in millions. And obviously, you know, that resulted in many of these departments being closed. And when I was a registrar, 20% of the chairs in surgery in the UK were vacant. So that's a huge problem. But I passionately believe that young people should go into research. It really helps them to understand things. I mean, it can advance their careers as well, but it's just so much fun. And I can tell you that when people start doing surgery, they want to do nothing but surgery. But after 30 years, you know, you're very lucky if you have something else apart from just going to the operating theater and cutting. So if there are any trainees out there who are listening to our discussions and they would like to pursue some research in surgery, we have 2 or 3 programs open at the moment. One is the biggest one is the primary hyperaldosteronism. That is if it works, it will change the whole thing about surgery for hypertension. We have parathyroids. We're still working on the national data for, and obviously I have colleagues who are quite active in research in other surgical specialties. But Joanna, I mean, we both work at UCLH and we talked about it. I mean, even last week, it was just so difficult, especially with the coronavirus. The bureaucracy in the United Kingdom is just phenomenal. There are the documents which are as big as 100 pages. They have to be, and there's very little distinction between little projects and big projects. You know what I mean? So if you just discovered a new drug to cure the cancer, you will get £1 billion and you can employ 10 people and, you know, and they can write the papers. But if you want to develop a little device which measures the parathormones in 3 minutes, you know, you still have to go through the same hoops, but nobody's going to give you money for that. So the small projects are very difficult to take off the ground.
Yeah, I agree with you. And we have the problem now of all the projects being stopped because of the coronavirus. And we're now having to write long justifications for why our projects need to be put back on. And as you say, a little project like one I've got, for instance, of a cohort and just collecting questionnaires is equal to a big major surgical procedure. And I think our R&D departments really aren't there to help us to move on and just put in more and more admin without helping the researchers. Yeah.
Well, it shouldn't stop us doing it, and it didn't stop you doing it. I'm still at it, but it is difficult. I entirely agree.
Okej, czy ktoś jest jeszcze może chętny do zadania pytania? Chyba już nie. To jeszcze raz Tomkowi chciałem podziękować, ale na koniec jeszcze, jeszcze jest pani doktor Zakrzewska.
Nie, ja tylko...
Klap.
Klap jest bardzo, bardzo przydatny i bardzo nam Pani doktor, to jeszcze tu panią dam na spotlight teraz i on odmutuje jeszcze sekundkę, jeżeli to mi się uda. Jeszcze pani nie słychać. Sekundkę. Jakby pani mogła... Nie słychać, co to się... Może jakby pani kliknęła unmute tam u siebie na telefonie. Dobra, teraz panią słychać. Bardzo proszę.
Bardzo serdecznie dziękuję, Tomku. To było naprawdę fantastycznie ciekawe. Ja się tyle nauczyłam i dla mnie to oczy się otwarły, będąc trochę starodawnym już chirurgiem. Bardzo, bardzo serdecznie dziękuję. Tom, thank you ever so much for this absolutely fascinating presentation. I must say I've learned a lot, and it's quite an eye-opener for us all these. So thank you very much. Również chciałam bardzo serdecznie podziękować naszemu sekretarzowi Tomkowi, ponieważ bez jego technologicznych umiejętności byśmy nie mogli mieć tak wspaniałego wykładu i tutaj zebrania w takich nietypowych warunkach, ale wszystko poszło bez żadnych usterek i za to serdecznie dziękuję. I wszystkim, którzy wzięli udział, tych, co zadawali pytania, tych, co nie zadawali, ale wiemy, że byli z nami. Bardzo serdecznie dziękuję. I zapraszam na naszą stronę, gdzie będzie można jeszcze raz sobie podglądać właśnie Ginetera, jak również na nasze następne spotkanie, które odbędzie się 22 listopada. Nie wiemy, czy będzie to możliwe spotkać się w instytucie, ale jeżeli tak, to może to będzie możliwe zrobić to jako kombinowane właśnie spotkanie dla tych, co mogą przyjść i spotkać się, i dla tych, którzy są daleko i będą się podłączać przez technologię. Także bardzo serdecznie wszystkim dziękuję, bo to naprawdę było bardzo ciekawe, wartościowe spędzenie niedzielnego poranka.
Dziękuję bardzo mi najbardziej osobiście brakowało tej części, czy brakuje tej części socjalnej, kiedy możemy się spotkać i jeszcze porozmawiać, ale myślę, że to z czasem uda się nam jakoś wszystko nadrobić. To dziękuję bardzo i dziękuję pani doktor, dziękuję wszystkim też. Wszystkiego dobrego, udanej niedzieli życzę wszystkim.
Dziękuję.
Dziękuję bardzo, nawzajem.
Dziękuję, do widzenia.